Nice to see some familiar faces and names. So I'm Adelina Comas Herrera and delighted to welcome you to this webinar today. The webinar is hosted by the Global Observatory of Long-Term Care, and I'm going to introduce you very briefly to the observatory and to our next events. The Global Observatory of Long-Term Care is a platform for cross-national learning to improve and strengthen care systems and is part of the International Long-Term Care Policy Network. And our aim is to identify key shared challenges and showcase how different countries, localities are addressing them, sharing research evidence and facilitating collaborations. And it's open to everyone. And the way it works is that basically it's a way that you can share your knowledge, and this can be through publications, through the interest groups, like today's webinar, for example. And we are also gradually building a database covering experts on long-term care by country, topics and methods, publications, research projects. And we now have over 60 videos of webinars, all tagged by topic, country, or method. So you can actually spend quite a bit of time watching very good long-term care content, if you like. Our next webinars after today are, first of all, one on home-based care outcomes. Does the care provider matter? That's some evidence from the US, from the Course Experimental Methods Interest Group. We then have one on the social connections in care homes and looking at how to measure, how to describe them, how to improve them, especially for people with dementia. And we then have one on quite an interesting topic, which is whether it's better to have private or shared rooms in nursing homes, looking at health outcomes. And again, that's also from the US. And we've got a few that we'll be advertising in the next few days. So do keep a look at the website because there's plenty more coming. And today's webinar is a shared, although all the work has been on the site of the Continence in long-term care group. But this is a shared interest between the climate change and long-term care interest group and the Continence care interest group. And I'm going to hand over to Javier, who's going to introduce the Continence interest group.
Thank you very much, Adelina, for this and for NAS for all the work and behind organizing this webinar. So I'm going to start a very brief presentation on the Continence Care long-term care group. So I'm Javier Jerez Roch. I'm the person behind organizing this together with Adelina and Naz, and trying to invite experts for every webinar. So as you know, bladder health is essential for aging, and urinary incontinence is one of the most important conditions affecting older adults. Here you can see some very dramatic data about the people affected in Europe, and the prevalence is even higher in nursing homes. The socioeconomic impact is also huge. Indeed, today we are going to see all the impact in the environment and how to improve this sustainability. And also the problem is neglected and underreported. Mostly the management is limited to absorbent products, and it's very difficult to have like innovations for the last decades. Also, research points out deficiencies in education, awareness, etc. So the aims of this group is to promote continence care in long-term care, to enhance people's dignity and well-being, and also to exchange knowledge, to network between stakeholders, experts, healthcare providers, etc. This is the steering group. So myself, Adrian Walk, Hannelore Stroban, Bill Gibson, Marilyn, and Thomas from the World Federation of Incontinence and Pelvic Problems. So this is a non-for-profit group. So as Nas put in the chat, you are invited to join to the group. So This is the third webinar. The group is 1 year old, more or less. So we are open to hear your ideas for the next webinar. So feel free to put in the chat your ideas for the next webinars. At the end of the webinar, we will also have some opportunity to exchange some ideas and questions. Okay, so basically the structure of this webinar, it will be as follows. Adelina already started. I also introduced the group. So now we will have the first experts. In this case, it will be Nicole Hughes and Thorsborn Ruthmark from SCT. They will have around 20 minutes to talk about shared efforts towards sustainable continence care. Later, Myra Robson from the Lewisham and Greenwich National Health System from the UK. She will have around 15-20 minutes for her presentation, which is called From Theory to Action, Implementing Sustainable Continence Care in Nursing Homes. And at the end of the webinar, we will have around 5 to 10 minutes questions and answers. So I'm going to introduce you then to Nicole and Thorsborn. Nicole is a representative of SCT. Nicole brings industry insights on collaborative approaches to continence care that balance value for residents, caregivers, health systems, and the environment. So in this session, Nicole is going to share perspectives on shared efforts and shared responsibility in advancing sustainable continence care practices. And Thorsborn, also representing SCT, is going to focus on sustainability and innovation with continence care solution. His contribution will explore how sustainable strategies can support high-quality care delivery while reducing environmental impact, emphasizing shared value across care setting. So, okay, the floor is yours, Nicole and Thorsborn. Thank you very much.
Thank you, Xavier. Hello, everyone. Yes, I'm happy to share or to start the presentation, which we have given the title Shared. And why did we give that title? Yeah, because it is very much about shared effort to take care of persons with incontinence, and also about shared value and shared responsibility. So you see the word shared coming back 3 times, because we believe that it is a shared effort to take care of people all healthcare professionals to take care of people with incontinence. It will also generate shared value for patients, for caregivers, care providers, healthcare systems, and the environment if solutions are provided in a person-centered way, and also making sure that there is a good connection between the care and the funding and the environmental perspectives. This also leads then to a shared responsibility to meet these challenges which there are in today's delivery of care for persons with incontinence. And we go to the next slide. Then, looking at the shared effort, you can say continence care can be defined as prevention, cure, and care interventions performed by different healthcare professionals. A systematic literature review from a couple of years back showed that, which was about cure rates, that study showed that the majority of persons with incontinence stay dependent on the management with toileting and containment care because they can't find a cure. So that is the reality. A lot of people are dependent on the management with toileting and containment strategies. And especially in long-term care, where the care-dependent people live, toileting and containment care, or in other words, toileting and management with absorbent hygiene products, is the main type of care provided, because people have all sorts of disabilities which make it a challenge to provide that care. So the use of absorbent hygiene products protect people with urine leakage, and is that thereby bringing a huge value as people can get on with their life, feel safe, secure, comfortable, and their well-being and dignity can be preserved. Looking more at this specific, looking more specific at the care process in long-term care, the use of absorbent hygiene products is very much a result also from how easy or difficult it is for people to access the toilet. And that, to a large extent, determines how much use there is of absorbent hygiene products, and thereby also the waste at the end of that process. So toileting and containment are interrelated, are very much interrelated. The challenge we have today is how to make this toileting and containment care process more sustainable. And for this, we need to look at multiple stakeholders. So like the healthcare professionals in this care, but also healthcare systems in which provisions are organized with funding, logistics, etc., and how these absorbent hygiene products are bought or procured, if you like, from different suppliers, and also how communities or community services are doing the waste handling, and also waste handling companies play, of course, an important role in handling the waste. So it's multiple stakeholders who can together collaborate to make the toileting and containment care more sustainable. Next slide, please. So if we look then at shared value, so it means that if we connect well and take this challenge together, we can create value. Defined provisions for persons with incontinence to manage their condition are in many cases not promoting environmental sustainability, and also buying processes for medical devices or reimbursement systems are not always promoting environmental sustainability. On top of this, recycling for absorbent hygiene products is not matured yet, even though there's a lot of effort placed and hard work done from multiple stakeholders to make progress here. So today we need to work with what we can do, what we can influence. And that is, in the first place, making a better match between individual needs of persons with incontinence and the care provided. Different studies have shown that there is room for improvement in long-term care to improve that care. And a more person-centered care will give the opportunity to improve the quality of life, in many cases reduce the total cost of care, and enhance the environmental sustainability. So having said this, I'm now handing over to Torbjörn so he can explain us in a bit more detail what the shared responsibility means in this toileting and containment care.
Thanks a lot, Nicole, for the introduction here and giving the kind of broad overview into this. And I would just like to then kind of emphasize this thing around sustainability. When talking about that, of course, it's the environmental part, but we have maybe more important the social part, the well-being, the reason why people are using absorbing hygiene products today. And then, of course, you also have the financial thing that needs to be in place in order for it to maybe become a long-term sustainable solution. So I will come back to that a little bit here during the presentation, but let's dig into the little bit more of the details, and starting from the life cycle of an absorbing hygiene product. And then looking at the different stages in the life cycle here, we have the upstream with raw materials, where you have the pulp, superabsorbents, and nonwovens being produced. Then you have the manufacturing part, where you actually are putting these materials together into an absorbing hygiene products. And then, of course, you have the logistic part, where products are being taken to different places. And then the usage part, and then at the end of life, which you touched upon here, Nicole, as well. And looking at the numbers below, these represents then the share of the footprint, the climate impact of the different stages in the life cycle. And it's very clear looking at those numbers that you have two big pots here. It's the upstream with the raw materials being produced, so the sap, the pulp, and the superabsorbents, and then at the end you have the end of life. Then the other part here, if you take the manufacturing part, for example, here it says 48% here, and actually less or 5 years ago we introduced certified renewable electricity in all our factories, and that took it for our products down to actually 2%. So there we have done a lot. So it's really about the raw material part, where we also are working a lot on that. And of course that involves both finding new materials with lower carbon impact, but also working a lot with suppliers on their energy. If they're using a fossil energy or renewable energy, has a huge impact of the footprint of the material. So there we are doing a lot in that sense. And then of course we are constantly innovating products to improve the kind of well-being, both in terms of functionality, but also in terms of efficiencies on the product as such. So that's for sure. And then if at the end of life, Nicole, you mentioned here that currently there are no real commercial technologies available in that. That is an area where we also are really engaged in finding solutions here. And of course, from a circularity point of view, the ideal situation would be in one way or another to try to connect the end of this life cycle with the beginning, in a way, to get a circular approach there. Of course, that with the kind of products we are talking about, the kind of requirements are really, really high on the material. So that's a challenging one. Then I would just like to focus in on the usage part. It says 0 here. And of course, from a product point of view, it doesn't really create any CO2 emissions by using an absorbing hygiene product. Having said that, though, of course, if you put ourselves into the shoes of a nursing home, long-term care facility, then of course the amount of product you're using, the type of product you're using, and so forth, has a big impact. So that actually takes us on to the next step here, which I think is one of this important thing around the shared topic which you initiated here, Nicole, because it's all about the kind of the way then the products are used in a nursing home setting. But in this equation, of course, you need to have the LCAs in place in order to do these calculations. And at Essity, we have been doing LCA since the early 90s. We have actually done assortment LCAs on the full TNS assortment since 2008 and tracked that. And I will come back to that later in the presentation here. So that is something that you need to have in order to do this. But then, of course, looking into the usage, which type of product are you using, how many products are you using, which absorption level, and so forth. All of these things matters, both for the amount of material used, but also actually from the functionality point of view. Because if you have the right type of product with the right absorbency level, you will actually have a better outcome in terms of leakage security. And I will also share an example in a short while here about that. And of course, less leakage, that means less laundry, both for clothes and bed linen. And that in the end takes us to the CO2 in use. So the kind of the end result of a sustainable continence care. So that's the kind of target, I think, that we're having here to by both having then the best type of products, but then using them in the best way will also generate a great outcome. And of course, that also has a positive impact on the social parameters, because that means a better quality of the care as well. So there you have positive benefits on both ends there. So I think this kind of shows the importance of the kind of shared responsibility here, that we are doing this together here in order to find there. And as you mentioned, Nicole, in your introduction, there are other stakeholders in the life cycle that needs to be involved, as well as waste management companies and suppliers of the raw materials to ourselves there. So what can we do? I mean, we have looked at the on-time toileting here, because obviously the best place is to continue to use the toilets. And that is, of course, something that should be part of a good continence management. Then also the optimal product selection is, of course, important, that ensure that the right person gets the right type, both in terms of product type, but also the size and absorption level. And then change on time, of course, also is an important one. And as a help for that, you can have different digital solutions, which I will come into a little bit more in detail here in a short while here. But that can, of course, both support then the toileting, the optimal product selection, as well as the change on time. Then, of course, we also have washable solutions available on the market today, but that's mainly really for the little leaks, not for when you have bigger needs, which you very often have in long-term care. However, having said that, though, of course, we are looking into alternative solutions where you actually have hybrid solutions, where you have absorbing material then being the disposable character, but then you have an underwear which really ensures to keep the absorbance in the right place over time. So that's an area where we actually are doing some innovation right now in order to find better ways of doing that, with using less disposable material and more reusable. So these are ways where we actually can implement then the CO2 in use, because in the end, that's really what will take us to a sustainable continence care in the end. Looking then at a little bit of these digital health solutions here, obviously at TENA we have the TENA Identify, which is of great importance when it comes to do a proper assessment to ensure this individual continence care, and I will share an example of that later on here. The change indicator that will then support on when to change the product, and then the latest part is, of course, also then is the bladder sensor, which then can help you see how much urine actually is in the bladder. But zooming in then on the TENA Identify solution, we have done quite a lot of different studies on this in different geographies. And what we've seen, for example, is that we actually can improve then the toileting part, an increase of 22% here in studies made in Sweden. We then did a bigger study in Canada as well, in a couple of different nursing homes, where we actually used the TENA Identify to ensure that you got the right type of product, the right absorbency, and the right size. So 40% of the users actually then had optimized absorbency compared to the starting point, and this was a well-managed nursing home we looked at as well. On top of that, we also then saw a 44% reduction of leakages, since you got the right product to the right user. And in total, that then resulted in a 15% reduction of the footprint. Roughly 10% of that was related to the reduced amount of absorbency material needed for each individual and number of products. And the rest of the 5% was then attributed to a reduced need for laundry due to the reduced leakages that we saw here. So I think this is a really nice example of where you actually can show these improvements of CO2 in use towards a more sustainable continence care. And of course, this is something that we want to do more of, to really see how we actually can improve these different parameters in combination with us then improving the footprint for the individual products used. But of course, this is, I would say, as important as improving the footprint of the actual products. But both needs to be done. It is, as we said, a shared responsibility and a shared effort that needs to take place here. Good. So before ending here, just a little bit on what we're doing. This one you will recognize because it kind of echoes what I mentioned about the sustainability. This is how we look at sustainability, not only for TENA, but at Essity in general. It's the social. We are improving well-being for people. That's what we do as a company, and what we are innovating for every day. But we, of course, need to do this in an environmental, sustainable way as well. So that's the kind of holistic approach we have on the sustainability work we are doing. Both of these things are always in our mind. And looking then on the environmental sustainability targets, I mean, we have the science-based targets, both the 2030 targets, scope 1 and 2 and 3, where both reduction targets is minus 35%. We are getting there, but we're also getting closer to 2030. So we are really speeding up on that one as well. But then, of course, the kind of long-term target are the net zero target by 2050. And I think that is also something that we've seen lately here now, that many of our customers, like are also having similar targets now. I mean, we have the NHS, which launched their net zero targets like 2.5-3 years ago. And we see that across Europe, actually, these types. And of course, it's easier when you have similar targets to also have these kind of shared efforts, which we have discussed today. How do we optimize the kind of care, but also the products used in the care in order to reach these targets? But there, of course, collaboration is of utmost importance in order to reach this, because no stakeholder in the value chain can solve this on their own. There needs to be a really strong collaboration in this area. I think that is very clear. And then just finally here, I mentioned before here that we've been doing assortment LCAs on the 10 assortment since 2008. And these are the numbers for 2024. So there is a new one coming later this year here. But as you can see, across the assortment, we have reduced the footprint between 17 and 46%, depending on which product category you're looking into. And this for sure is something that we're on a continuous basis looking into. For every innovation we do, we also have environmental sustainability targets, and we actually look really early on in the innovation phase as well on how the different innovations actually influence the footprint. We have some tools that we use in that phase. But I think that takes us to the end of this. And I'm happy to take questions afterwards. I think that's how we said Javier here. So thanks a lot so far.
Thank you very much. Very interesting. We have a question in the chat. I'm not sure if we should answer now or at the end of the webinar. I'm not sure. What do you prefer?
I'm fine with either. If we want to wait, that's fine, or take it now. It doesn't matter.
It is.
It's the wording of absorbent hygiene products. Do we mean only for incontinence, or also they can include other aspects like menstruation?
Yeah, I guess what I've been talking to today are the ones for incontinence, but looking then at the material in a female hygiene product, of course that is very similar. It's non-woven, super absorbents, and pulp there as well. Of course, different features since it's not urine but blood that they should cater for. But in general, I mean these things around. If we look at the end of life, I would say that's very similar from that perspective. I don't know if that was an answer to the question.
Okay, thank you very much. So if you have more questions, feel free to use the chat. And also at the end of the webinar, we will have the chance to open the microphones and just intervene. Okay, Mayra, is your turn now. I'm going to introduce Mayra, but I think maybe I already did it, right, Mayra? So yeah, you can just, well, I can do it in 1 minute. Mayra is a physiotherapist. She's an expert in pelvic health. She's also a leader on continence care in several nursing homes. Yeah, she has worked extensively to improve continence services and promote patient-centered care pathways. So in this webinar, she's going to discuss more practical implementation of sustainable continence care in nursing homes. Thank you, Mayra.
Thank you very much for inviting me. Can you see my presentation there?
Yes.
Fantastic. Okay, so I work in the NHS in London, and one of the aspects of my service is to support continence in care homes. I took over this role in 2019, and I have to say that managing products and care homes has probably been the most challenging aspect of my career to date. So I'm going to talk a little bit about what we've tried to do and what it's like to actually put some of these plans into practice in somewhere like the NHS. So this is summarising a little of the project that we're running called the Pear Tree Project. We have 15 care homes in our London borough of different sizes. The smallest is 4 and the largest has nearly 90 beds in it. So it's a lot of patients in care homes, both residential and nursing homes. The nursing homes in the UK have qualified nurses in them. Residential homes have healthcare assistants and similar staff. So over the last few years, we've done a number of things to try and improve our presence in care homes and the continence care of the residents. We've implemented bladder and bowel champions in the care homes. We've spent a lot of time building relationships. We have one member of the team that's dedicated to working with them and time set aside for that work. We've tried different methods of training and supporting the staff. We've developed simplified assessment forms that are realistic for staff to fill in with a very, very simple assessment, bladder diary just for a day of voiding frequency, a day of managing leaks, and also of how much they drink. We've set up a dedicated email for the staff, so they've got a simple way of approaching us, not through all of the normal NHS red tape, which can be quite considerable. And we found that we were doing relatively well with that, or we thought we were. And so we came up with the idea to do something called the Pear Tree Project. And this was to see how continent could we get one care home called the Pear Tree Care Home in 1 year. And we managed to secure some funding for a healthcare assistant for that. Now, as soon as we started working on that, and we went into Pear Tree and started to audit the patients there, we realized that all of the wonderful things we've been putting into place just simply were not happening. So the assessments were being completed incorrectly. You could get 5 bladder diaries and they would all be identical because they would just do copy and paste. We were struggling to get any interest in continence issues at all. Training was really, really difficult. Staff turnover was very high. So as soon as you got one person on board with what you were doing, they would be off to a different job. And the working conditions in care homes in the UK are really challenging. It is a low paid and low value job. And so you're having people who may not have English as a first language, people with perhaps not a great interest in the work, I think it's fair to say, but it's work that people are able to get. And it's just not very motivating to work in the field. Obviously, COVID had huge impacts on the work we were doing as well. And being in a care home is quite difficult to provide an environment where you can really support patient care. So we did trial going in and assessing patients, but patients are in open areas. It would be very hard to get them into a private area where you could treat them. And so that made it difficult as well. So within a matter of weeks, we decided to completely redo our plan for how we were going to manage this project. So what do we find as being some of the big issues from our work so far? There are absolutely ingrained core beliefs about aging and about the impact of aging and incontinence and the use of pads. And trying to turn this around is really difficult. Product use is rife, and that is considered to be the main way of managing continence issues in this client group. In London, the transporting of products is an issue as well. It's a big area, there's lots of traffic jams and lots of lorries chuntering along, sending out all of their exhaust fumes. We found that care homes really struggle to store their products correctly and to use them correctly. And we found that there was a huge problem with staff taking products from one patient, sending them into another room, not knowing the difference between the different products, even though we prescribed them carefully for each patient. Also, enormous amount of waste produced with product use, not just the products themselves, but staff wear aprons and they wear gloves and they're using wet wipes. And then there's all of the laundry as well, which has been alluded to already. So what are we doing in our care homes and what do we find that has worked? We've worked on 15 so far and we've done 5 in depth, and we're just waiting for a new healthcare assistant to join us to continue this work over the next year. I think one of the biggest things to work on is relationship building, developing those core relationships with care home managers, with the clinical leads, with the staff who work in there. We sent our healthcare assistants in there to work day after day with them, to get to know them, to understand how that care home ticked, to understand what problems staff were having, and to build trust and to build that involvement in the plans what we had for them. And that was really very effective. We also did quite a significant focus around the products. We want to see how continent we can get our care home residents, but we are a long way from meeting that. So to start with, we decided to focus on the fact that products were being used extensively. Let's at least get them used correctly and build from there. So each care home that we go in, we do effectively a spring clean in there. We audit everybody in the care home. We check them all against the records that we have. We make sure that the patients that are on products, which is most of them, are on the right products, that it's the right numbers of them, that they're in the right place. We went round and did audits on the patients' rooms and on their cupboards. And there was a sort of comical scene where we opened one cupboard door and literally a cascade of pads fell out on our heads. We check that the products are being used correctly. That makes a huge difference to whether or not they're effective. Are they being changed at the right time rather than just being changed routinely? And we set up product labels in the wardrobe door. So a member of staff can go in, open the wardrobe door and look and see what product that person should be on. We looked around product delivery. We made sure that staff were ordering their products on time. We have 4 weekly deliveries in care homes because they cannot store more products than that. And so ordering on a regular basis is really important, or else they were running out of products. Then they were borrowing other people's products. Then that person ran out of products. Then the care home staff were going out to buy products. That's eating into the funds that the care home has for things like social events. And that's just not acceptable. We taught them how to check the stock. Occasionally errors arise and they need to know that and flag that up with the delivery company, but also how to label the products to go to the right floor, the right wing of the care home, the right room. We have changed our delivery frequency to our individual homes to 12 weeks to reduce the impact of traffic. But we cannot do that in the care homes because of their storage areas. But we're hopeful if we can reduce the number of products people need to use, we can increase the time between deliveries, and that will have a sustainability impact as well. We've established dedicated staff to manage the stock itself and to return any unused stock. And in some care homes that are used for patients being discharged from hospital, we are setting up buffer stock, again, to stop them having to borrow the correct prescribed stock of other residents. And we found that in Pear Tree, which is a home of around 75 beds, that we can save £250 on products just by getting these into action. We've worked closely with our product representatives and they've been incredibly helpful. They can give us data on which care homes use the most products, and they also attend the care homes with us and they train the staff on how to use the products correctly. Not only do they know the products best of all, but it also saves us time and releases that for patient care. And then we've tried to implement some basics around toileting. And when we walked into Pear Tree, they've got a beautiful glossy section for the patients with dementia with lovely ensuite rooms. And each ensuite room has 2 identical white painted doors with no signs on them at all. Now, if you're a patient with dementia with 2 doors in front of you, one's a wardrobe and one's the toilet, it's not surprising that's somewhat off-putting when patients need to go to the toilet. So we've got toilet signs on the doors. We have a folder in each resident's room which has all of the details on their toileting needs and their product needs. And we've promoted timed and prompted toileting for the right patients. And we found that one patient, we managed to stop nighttime leaking and nighttime product use simply by bringing forward their cup of tea to about 6 o'clock instead of 9 o'clock and getting the staff to take them to the toilet around 10 o'clock before they went to sleep. So often it's the simplest of things that can make a huge difference. So what are my key messages? It's starting really small. Don't aim high. Don't have a huge plan because in my experience, it just won't work. So start with something small. We have a great expression in the UK, the devil is in the detail. So go down to the detail, pin down exactly where things are going wrong at a very fundamental level, such as the pads being delivered and going to the wrong room. Spend time in the care homes. It's time well spent. Get to know some of the staff there, get them used to your presence, pop in unexpected, that keeps them on their toes if they're not doing what you want them to do. Build relationships and build trust. Make them feel that you're on their side because their job is often extremely difficult. Work closely with your product manufacturers. That works really well for us. And simplify pathways. If somebody in a care home can just email a clinician to get some advice, they're more likely to do so. If they're pushed for time and they've got to fill out a long and complicated form, there's a good chance they won't do it. very happy to take questions.
Excellent, Myra. Super interesting. Thank you very much. So you have a question in the chat from Andrea. You mentioned deliveries every 12 weeks and buffer stock. Do your nursing homes receive additional deliveries upon arrival of new residents?
It's a very good question. So 12 weeks is for patients in their own homes. We've had to stay with 4 weeks for care homes. What we're aiming to do is, as I say, for the ones that take residents at short notice for respite care on discharge from hospital, we're aiming to set up simple buffer stock for them to use to manage that situation. But we've also set up something within the 2 hospitals in the trust where if a patient is being discharged on products, they have to be discharged with a week's worth of the products they've been using. And at the same time as the ward is planning the discharge, they have to email our team so that we can take over that immediately and hopefully not have a gap in the product delivery. And at the same time, we can assess the patient and see what we can do to manage their needs and get them to use less products or no products once they come home.
Thank you, Myra. Okay, more questions. Another from Marian. Have you audited patients switching to continence management products other than pads and found a more beneficial outcome?
Is that for me?
Probably yes.
We have tried non-disposable products, and I have to say that it's really very hard to get people to switch to them. So we use washables, and we use washables from about 650 mils upwards, but they're not all that popular. You have to have the right sort of person, the right sort of environment, and the care homes are not keen to use them at all. We've also tried and use convenes and external catheters and men's liberty, a whole range of things that we have. But getting the staff happy to use them is a big challenge. But that is something that we want to do. Once we have gone around all 15 care homes and done the spring cleaning and got the basics right, then we will be aiming to do a series of micro interventions, starting in 1 care home at a time and trying things like non-disposable products, time toileting, decaffeinated drinks, medication reviews. So just a small intervention with a small group of patients, learning from that and then spreading out the ones that are effective.
Thank you, Mayra. Another question. Would additional training for sheets at Citra be a benefit from industry nurses?
Yes, if they're going to be used, and that's the problem we've had. We've tried to implement sheaths and liberties and Duracaps, all kinds of things, both on acute wards and in the care homes, but the staff really struggle to do it. So you need to have sufficient staffing, you need to have a really dedicated clinical lead on the ward or in the care home who's prepared to really push it through. And that is a really challenging thing. So all of those things I believe are possible, but they take a lot more work and effort to implement than you could even believe possible. It took us a year with a healthcare assistant to manage 5 care homes and turn them around. And they've kept the improvements that we've described in the presentation, but that's a huge amount of time to make a difference. I think yeah, I've been working on this for 5 years and it's quite extraordinary, the barriers that are there to overcome. So I think all of these are really good points. They're on the list, but probably won't happen very soon.
Thank you, Mayra. You are doing a great work there. It's super interesting. It would be very interesting at some point to do a cost effectiveness analysis, but still you need more time to do research and to show indicators. So and we know that there is a lot of barriers in nursing homes, as you said. Andrea, which have been the main observed improvements according to your experience?
For me, it's been the attitude. So it's working with the care home managers. Again, often they turn over, but working with the senior staff in care homes who now know who we are, who know bladder and bowel care exists, and who know that incontinence and aging do not necessarily go hand in hand. And just changing that fundamental attitude has been the best thing. So now when the clinician who runs this rings up and says, hello, it's Sue. They know who she is. They know which team you're working for. They come to us with any questions. And we've had 3 queries in the last 4 months where a care home member of staff has emailed us to say, we think person X could actually get a bit better. Would you come in and talk about bladder retraining with them or something similar? And that's been the first time in 6 years that care home staff have actually asked us to treat people rather than pad people up. So for me, that's a huge improvement.
Very nice. Question from Alan Cottenden. Do you think the improvements you have achieved will be sustainable without additional staff?
No.
No.
No, I mean, it's a full-on job. It really is. We had to go much, much slower. As soon as the healthcare assistant left after a year, we've had to campaign for more funds. I want to enter it for awards and write it up and such like to try and attract more attention to it. It's clearly a very cost-efficient process. We use the healthcare assistant band 3 in the NHS, which is really not a very expensive grade, and it worked brilliantly. But despite everything the NHS says about moving to prevention rather than treatment, etc., trying to get these things in place is really, really difficult. So no, if we're not on top of it, the staff turnover, old habits kick in again, and I don't think it's sustainable. So I'm doing my best to make it sustainable, but it is an uphill battle.
Yeah. Okay, more comments, questions? Andrea, how is it cost efficient while needing extra mancraft?
So for example, the time that I sent the healthcare assistants into the largest care home to help organize their products, it took 2 hours of her time, which would be around about £40 to organize the products, and we saved £250 in products. So just managing the products itself was cost efficient. If we can get people toileting and managing the fluids correctly and so on, then the staff would spend less time taking people to the toilet than they do changing the bedding, changing the pads, cleaning the patient. Also, it has impacts on patient mobility. So if the patients are getting up and moving about, that's going to be better for their tissue viability, better for their circulation, better for their quality of life. So I think I've predicted it would take probably 2 to 3 healthcare assistants to manage this across the 15 care homes, and with us sort of supervising from the team side. And then I think we would save probably double their salary in product reductions.
Mm-hmm. Okay, more comments, questions? Otherwise, I have one. So before Thorborn showed this very nice figure with the whole process. The last one, as far as I remember, on the right is the waste management. Do you have any tips or recommendations? This is a question for Mayra or for Nicole or Thorborn. Any specific, very easy recommendations, tips on daily practice for healthcare providers in the nursing homes on how to do the recycle and the waste management of the absorbent products?
Sorry, you go.
No, I think there are multiple answers to your question, Xavier. I think we tend to focus on the end of life, but I think we also need to start, like Mira also expressed, look at the assessment of what does a person need, and are we making the right match? Because there, I think the process should start. So making a good assessment of toileting, on-time toileting, and providing the appropriate product for that person's need, together with changing on time and those type of things. So I think that is having a huge impact, or can have a huge impact, dependent on, of course, which care home and in which country, etc. Then I think there can be gains also at the end of that care pathway of the value chain.
Yeah. I can maybe just build on that, because I think it's a really interesting question there, Javier. But to some extent, it depends on what kind of if you take recycling technology you have there in the end. But the general principles of recycling is, of course, you want as clean streams as possible. You don't want to have too much mixed into one. So I think that could be something in the future here, depending on which technology will come out here, on how we actually ensure that we get the right type of material. Because Mira, you mentioned also that was a lot of other material used when changing. Of course, you have aprons and gloves and all these kind of things. So I think that is definitely something that will become an important part of that solution. But as I said, a little bit depending on which technology you look into. Some are more kind of forgiving and some are more specific. And of course, the more specific you are, the more detail you need to be in when you sort. But I agree with you, Nicole. The less material you do get into the end of life, the better it is. Of course, we need to work on a lot of different things to ensure that.
I think from my perspective, one of the biggest things I've found is that people just don't understand pads, and they think that because they think they're just so simple, it's just a pad, and it's not. The technology behind the pads that people like Essity create are quite phenomenal, and how you use it can make a huge difference. So we use a product that has indicator lines, but staff rarely look at the indicator lines, so they often would change according to a schedule, which if you're in a home or you've got carers coming to the home 3 times a day, often that's unavoidable. But in the care home, you need to be checking, does this product actually need to be changed? So we have a lot of products being changed when they don't need to be changed. And so I think if we use them correctly, make sure they're the right fit, I think that can make a huge difference. And also the more absorbent products have, I'm assuming, more chemicals and things like that in them and more stuff in them. And often they're not needed, but people think more absorbent products are just more secure. So they're always pushing for that. Again, we're very careful with assessing somebody, making sure their product fits their requirements. So I think just getting the right pad for the right product at the right time can go a long way to reducing the level of waste.
Okay, thank you all. Another question from Alan to you, Thorborn. Does the environmental map look different from country to country, or are there strong similarities?
Well, that's also a really good question there. And of course, I mean, we're a global company. We work across the globe here. But if we limit ourselves to Europe initially here, I think that also there actually you do have some differences between different countries in that sense. And for one, of course, the best place to put a used absorbing hygiene product today is into an incineration with energy recovery. So at least you get some of the energy which you put in the beginning of the raw material production back. But of course, we also have countries which are pushing the recycling a little bit more than others. I mean, there are a facility in the Netherlands, for example, and the Dutch government has done a lot in this area as well. And we are working together with them there as well in order to find this type of solution. So yes, there are definitely differences between countries, I would say, on the environmental map, also in Europe. But of course, everyone is looking to find these type of solution, because in the end, it's also about finding a way to have less going into the municipal waste stream. I think we all recognize the kind of sorting everyone is doing today on different packaging material and things like that. And looking then at absorbing hygiene products, that is now, I think, like 8-10% of the total municipal waste stream. And of course, that's a trigger for municipalities to look into these type of recycling alternatives.
Okay, another question for you from Manuela. There are already ways to use absorbent products to produce energy. What do you think about that? Why is this not normal today?
Yeah, as I said, I mean, that's the best way of doing it. It's to incinerate and recover the energy. So that's the recommended way today. But I guess that's a bigger question. Looking at Europe today, I think we have seen a shift over the last 15 years from landfill to incineration. But then you could argue, okay, is incineration with energy recovery the best, or is it actually better to see if you can actually capture some of the because what we're talking about here is also looking into, or what we are exploring are actually chemical recycling. And then you're actually just breaking polymers apart into monomers. And the gas that you get out of such a process, you can actually use to build new polymers that you can produce new material like nonwovens and superabsorbents. So maybe that is a way. And I know that that's something that a lot of the big chemical companies are looking into as a alternative, because they want to phase out the fossil carbon in essence and want to replace that with something else. So that could actually be the next step. But of course, that's also technologies that needs to be developed. And there is a lot of work ongoing there in that area, which we are supporting as well.
Mm-hmm. Thank you very much. More comments or questions? My sensation is that this is like a topic, very new topic, and I think that it's a lot of work to be done, a lot of innovations too. Let's see what happens in the next years. No more questions. I have a last question otherwise. Mayra, you said that selecting the correct product is very important. In practical terms, Mayra, how do you select the best product for its resident? Do you do it through like in an interview, or do you use some kind of resource? How do you do it in practical terms?
So we have set up simplified forms for the care home staff to do. So they will do a 1-day fluid intake diary, a 1-day voiding diary, and a 1-day leak incontinence symptoms type diary. And they will fill out a simplified form where we're looking at what the patient's dexterity is, mobility, and their sort of cognition. Do they toilet themselves? Do they need support? What are their bladder and bowel habits? Any key medication or past medical history? Those forms will be sent into the care home lead. She will look at them. She'll phone the care home staff if there's anything there that needs to be clarified, and then she'll base the products on that, as well as giving them advice on what to do in terms of toileting or anything else like that. The guidelines do suggest that you shouldn't give pull-up pants to people in care homes because they've got 24-hour care. However, we will do that if somebody is independent with pull-up pants but would not be independent elsewhere. So patients with dementia, for example, often take out shaped pads or insert pads and launch them around the room, throw them out the window, do all kinds of things. So they will often manage pull-up pants quite successfully. So we will prescribe those for patients with dementia. But we have done an interesting trial recently. We can have samples of products. We get 1 or 2 samples from our product company here in London. And we've done a trial with them of giving a 5-day sample of the products that we prescribe to patients with dementia who are used to using pull-up pants themselves, and seeing if we can get them onto shaped pads instead of the pull-up pants, which are often better, particularly if people are lying down a lot or during the night. And we've had really good results with that, where around about 40% of patients who are used to using pull-ups will switch to the shaped pads. This has positive clinical implications, particularly if their dementia journey increases. Also has quite big cost implications because the pull-ups are around about twice the price of the other products. And a lot of hospitals in our area have stopped prescribing them altogether. But I don't believe that's clinically right for some patients. So that's been quite successful. We're now going to the second phase of that audit to see if we can bring that down to a 4-day-a-week trial, and then look at how we can actually fund that, because currently the company is funding that for us and we can't manage that. That's not fair on them. So there's some interesting work around what happens if you really support people to use the right products when they've been used to using products that are not perfect for them.
Thank you very much, Mayra. Okay, so I think we are on time. I would like to thank you all the speakers. It has been super interesting. We are now running one project which is called Procon. Emma and Andrea posted some information, so it's a non-for-profit project. We are finishing some courses, some training for healthcare providers and students. And indeed, one of the topics of the courses is sustainable continence care. So yeah, just in few months, I think we will be ready to have the courses open and free access. And yeah, in the meantime, feel free to reach us in the links that Emma provided. So thank you very much, everyone.